Thank you, Jeremy, for your kind introduction, and thank you for the All India Ophthalmological Society for the invitation of the talk. So today I will talk about some of the studies that our group have performed in Hong Kong about using a SMILE, which is lenticular extraction in the correction of myopic astigmatism. As you already heard from our previous speaker, you know that myopia is very prevalent in Hong Kong, but myopic astigmatism is also very prevalent in Hong Kong. And corneal laser refractive surgery has become increasingly accepted worldwide as a safe and effective treatment for refractive error. And among all, PRK, LASIK, and SMILE are the most commonly performed refractive procedures here. And accurate astigmatic correction is essential for achieving optimal unaided vision after the surgery. And there are few studies actually evaluate astigmatic correction after SMILE using vector analysis, which is recommended for reporting astigmatic outcome. And for information, SMILE is approved by the FDA in the US for astigmatic correction up to 3 diopters since 2018. So we use vector analysis to evaluate astigmatic corrections. So what it is? So basically, we perform some calculation and evaluate the change in astigmatic axis and vectors, and we calculate the relationship among them. So some of the parameters that we will measure include the TIA, the target induced astigmatism vector, which is the astigmatism and the direction that we aim to correct, and the surgically induced astigmatism vector, which is the actual correction that we perform. And the differences vector is our vector difference between the TIA and SIA. And magnitude of error is the arithmetic differences between the TIA and SIA. And the angle of error is actually the angle between the SIA and the TIA. So which is the how much degree that that is beyond planned correction. So this is the relationship showing in a diagram. And so the first study, we compare PRK versus SMILE in myopic astigmatism corrections. So in this study, we included patients with highly myopic eye, which is more than 6 diopter, and a low to moderate astigmatism, which is less than 3 diopter. So we have 34 eyes that has SMILE corrected, and 32 eyes with PRK performed. And no preoperative differences between the two in terms of the refraction. However, patient with PRK tends to have thinner cornea, and we measure the visual and refractive outcome in 1, 3, and 6 months. And for the result, all surgery uneventful. And however, for people after PRK, most of them have mild corneal haze, but most of them resolve within 3 months. And by 6 months, 97% of eye and 94% of eye are within 0.5 diopter of the attended spherical equivalent correction after SMILE and PRK. And all eyes, and only 69% of eye are within 0.5 diopter of the intended astigmatism corrections. So you can see in here the DV, the defensive vector, and the ME is significantly lower after SMILE compared to PRK, and the absolute angle of error is wider also in the PRK. And this is the predictability graph. You can see the surgically induced astigmatism versus the TIA. You can see the green arrow here. For PRK, there is overcorrection with higher magnitude of astigmatism, but there is slightly undercorrection for the SMILE group. So in conclusion, both SMILE and PRK are observed to be safe, and the predictability was better in SMILE compared to PRK, and there are trends towards overcorrection following PRK. And this study has been published in Scientific Report. So we also compare LASIK and SMILE for correction of low to moderate astigmatism. 11 eyes with really a balance between the two groups, and there's no difference between the two groups, and we evaluate the outcome up to 3 months. And the result showed basically at 3 months, 76% of SMILE people has achieved an uncorrected distance vision of 25. And however, there are more eyes, 95% of eyes attaining a 25 visions. And in terms of astigmatic correction, 97% of the eyes after SMILE and 98% of the patient after LASIK has 0.5 diopters of attempted cylindrical corrections. So you can see here the DV is significantly lower in LASIK group, and the absolute angle of error is also lower in the LASIK group. And you can see on the left side is there's undercorrection of astigmatism in smile, and on the right hand side is the LASIK, which is quite accurate. So you can see in this study, smile offer actually a less favorable astigmatical outcome compared to LASIK, and the angle of error is wider, and also the absolute angle error is also wider. And this study is published in the BJO. And then we try to evaluate the patient who had high myopic astigmatism correction, and which is we define at 3 diopters or more. So we have 40 eyes undergo smile and 65 eyes after LASIK, and there are no significant difference between the group. And we also evaluate the postoperative 3 months result. So you can see the average preoperative cylinder was around minus 3.4 diopters, and similar between groups. And by 3 months, basically all eyes are able to attain in 20/25 visions, and 82.5% of eyes is more in the smile group, and 83% in the LASIK group attain 20/20 or more. And 90% of the eye in the smile group and 95% in the LASIK group actually attained within 0.5 diopter of attempted cylindrical correction at 3 months. So you can see after the vector analysis, you can see they are pretty much similar between groups, and also this is the graphic. This is the TIA versus SI versus TIA graph to show any under or over correction. They are pretty much the correction is quite good. So this is the spread of the angle of error. You can see the spread are pretty much the same, a bit wider for smile. And the absolute angle of error reported in the current study is around 1.88 degree at 3 months. And previous study also show a similar degree of around 2.24 degree. And also another author from India, Sharikinish, also show a angle of error of 2.31. So we pretty much achieve a pretty much similar axis rotation alignment between amongst other study. And mind you that there is a trend towards better treatment alignment with higher preoperative astigmatism, and we believe that this observation could be due to the better evaluation of axis location, usually in moderate to high astigmatism. And this is also consistent with previous study. So in conclusion, SMILE offer comparable astigmatism correction to LASIK in eyes with high myopic astigmatism, and the centration and alignment of treatment is purely subjective in SMILE. So therefore, it relies on patient fixation and also the surgeon application of the suction contact glass on the eyes. And therefore, meticulous intraoperative position is very important. And this study was published in JCRS previously. And so we want to know about the learning curve of SMILE. So therefore, we evaluate patient after SMILE during the first 2 years of experience. And so for the first year, the first 100 eyes, we put it in group 1, and the late 100 eyes, we put it in group 2. There was actually no difference between the preoperative background between the two groups, and we evaluate the result up to 6 months. And for the case, there's one case of suction loss in the group 1, and also 4 cases in group 1 has tear at excision during the surgery, and only 1 case in group 2. And the efficacy index was actually better in group 2. And also at 6 months, the uncorrected vision and also the efficacy index are similar between the two groups. And in the group 1, 90% of the eyes are treated within 0.5 diopter of astigmatism corrections. But in group 2, there are actually a high percentage of eyes attaining 0.5 diopter or at 1 week, 6 months. So you can see when we compare group 1 and group 2, the DV and also the angle of error was significantly better, lower in group 2, which is which were the patient, the later 100 patients. So this is the graph. And so the duration of docking and also suction engagement was also different. Between group. You can see the treatment duration was shorter for the group 2. And because if we are not familiar with the surgery, there are more manipulation, and this manipulation could lead to a slower visual recovery. And the review of literature also shows similar outcome compared to our studies. And there are more information, as I mentioned, if you have more, if the surgeon was inexperienced with the surgery, and difficulty in lenticular extraction will also associated with has been shown to associate with irregular cornea topography. And so apart from the easiest of lenticular extraction, patient positioning docking is also important. So, so in conclusion, proper treatment sensation, efficacy of docking, and such engagement is very important. And faster visual recovery and better outcome are more accurate. A profile provide more accurate and estimated outcome compared with surgical experience. So this study was published in Cornea. So I want to show further about ocular residual astigmatism. So what it is actually the astigmatism apart from the anterior surface of the cornea. So we perform some study and we compare the patient with ORA, and we find that patient with high ORA, that means the patient with more astigmatism in apart from the anterior surface of cornea, show actually a worse correction of astigmatism correction. And this study actually was published as a letter in JCRS. And further on, we evaluate the efficacy of treatment the patient. So we
sorry to interrupt, sir. Yeah, the time is up. You could just conclude it within 1 minute.
Yeah.
Sir.
Okay. So let's. I will forget about this. So basically, what we want to when we perform SMILE, we would have this preferred practice. So for planning, we will look for the amount of cylinder that we want to correct, ocular residual astigmatism, and we will want to perform cornea preoperative marking, and we want to position the patient well and do cycle torsion control. And during the docking, we want to assess the angle kappa and keratometric astigmatism, which can help to improve the accuracy. And of course, for during the surgery, we want a smooth dissection and also a complete extraction. And so thank you very much for the attention. Thank you.